One, please start, sir. We are live.
Okay. So, good evening, everyone, all the audience and speakers. We are privileged and honored to have today with us Dr. Rish Nigam sir from Shankar Netralaya, Kolkata, Dr. Antonil Ghoshal sir from Shushrut Eye Hospital, and Dr. Shubham Sinha sir from Shankar Deva, Shankar Deva Netralaya from Guwahati. Sorry, my bad. And our first TV speaker is Dr. Ishnigam sir, and he will taking us through the presentations, translating research into practice, real world applications of DME management strategy. Over to you, Ishnigam sir.
Yeah, thank you so much. Good evening,
Thank you.
everyone. First, I will share my slides. Are my slides visible?
Yes, sir. It's visible.
Yeah. 1 minute. Yeah. So, the flow of my presentation is between a comparison between the randomized control trials of the diabetic macular edema into the real world evidence and practices. So, what are the limitations of clinical trial designs and its outcome? It is the strict criteria in the clinical trials which can limit the generalizability of the results and the lack of consensus on the ideal treatment regimen of like treatment and extend and PRN. And the results may not fully reflect the real world complexities of the disease, like the treatment burden, the compliance of the patients. We have seen all the three molecules, ranibizumab, faricimab, and brolucimab, with a vast supportive data of their studies, and they have the robust role in diabetic macular edema. The aflibercept efficacy is also supported by the Vivid and Vista trials, which is a trial for the aflibercept. When compared with the macular laser, the aflibercept after 5 monthly dose, we in the Vivid Vista trial, they have 2 and 8 monthly, and then that was supported for the 3 years, and they have found that the patients subjected with the aflibercept performed much better. Also, the DRCR net protocol T recently that also showed the aflibercept superiority among other agents. So there is a need for real-world evidence to complement data from RCTs and support the treatment decisions. What is the real-world evidence model? It measures the real-world effectiveness in the clinic. Patient population is unselected, diverse, and not pre-screened, and treatment is based on physicians' decisions, and typically includes very diverse outcome measures. So it provides essential information on patient impact, worldwide differences of various approaches of the same diseases, and the value of the treatment. So the endurance study was the 2-year extension of the VISTA study, and in which they found that there was a fewer number of injections was required in the next 2 years for the patients who were subjected for the aflibercept, and patients were observed for 4, 8, and 12 weeks intervals depending upon their disease stability, and there was a substantial reduction of treatment burden and required 25% of patients required no treatment, and 48% of patients received 5 or fewer injections in the next 2 years. So all the real world visual gains were consistent with aflibercept along with the randomized control trials, in which they have supported like Apollon and the Moorfield studies. The early to start the therapy with aflibercept and with poor patients with having a presenting poor visual gain, and they resulted with a better outcome. Not only that, patient having a presenting vision of 20/40 or better, they maintained the vision throughout the year. So we will see in further discussion also. So there were a mean BCVA change at month 12 in treatment naive patients with which was plus 2.5, 12.2 letters. And for those with BCVA less than 70 letters, mean BCVA change at month 12 was plus 7.3 letters. And not only the visual gain, but there was a stability in diabetic retinopathy severity, which was remained stable from the baseline to month 12. So data from Moorfields Eye Hospital and other trials, they shown that more patients were presenting vision of less than 69 letters or less than 20/40. And when they were subjected or switched from ranibizumab to aflibercept, they have a good visual outcome and they performed much, much better. So this was the study from our Kolkata group only, and these are the in the Indian eyes when the aflibercept was compared with the dexamethasone molecule, and then they found there was almost for the recalcitrant DME, and there was a visual gain in aflibercept group, and but there was a risk of higher IOP in dexamethasone group, and there were much aflibercept group required much more injections and follow-ups as compared to dexamethasone group. But so this was the another study which gave the consensus for central involving diabetic macular edema, in which anti-VEGF therapy is much more effective in improving vision. And when there was a choice of switch, the aflibercept was the first choice to switch from ranibizumab or bevacizumab. This was a VRSI consensus, All India Ophthalmological Society and VRSI also consensus for this. So not only the Indian studies, there are other international recommendations for the guidelines with the first line use of aflibercept in patients presenting vision less than 20/40. So here's the level of evidence in which the meta-analysis makes the highest level of evidence, and the Cochrane meta-analysis reviewed evidence from major studies investigating the efficacy of anti-VEGF agents in DME, and they found that patients were 30% more likely to gain more than 3 lines with aflibercept than with ranibizumab or bevacizumab at year 1. So this is the most highest level of evidence which supports the efficacy of the aflibercept than other molecules. Not only this, the other meta-analysis also suggests aflibercept is the most favorable treatment for the patients with DME, and they have all suggested that aflibercept is the most favorable treatment in the terms of BCVA improvement and central macular thickness reduction compared with the other therapies in the management of DME within 12 months. So international guidelines and recommendations all suggest that more early to start with the therapy, and in particularly in treatment naive patients, the better is the visual outcome. As we have seen in all robust protocols and the studies, they have all compared with other agents to aflibercept for their efficacy and superiority. So aflibercept is the recognized as the standard of care in DME and is being used in 4 DRCR retina network protocols evaluating anti-VEGFs in DME and diabetic retinopathy. So this ends my presentation.
Thank you
Thanks.
so much. Thank you so much, sir, Nigam sir, for so much for that elaborate presentations. And even after that elaborate presentations, also we are open to take query even if they're with audience. So if there is any query from audience end, we are good to like have that query and take that query. We are open to take that query. Okay. So
I
I
think
think no, sir.
questions after all the
Yeah,
talks
that
also okay.
that could be done. So yeah. So we are moving to the next presentations. So our next speaker is Dr. Antonil Ghoshal, sir, from Shushrut Eye Hospital. Sir will taking us through the presentation evaluating the need for change evidence and insight on anti-VEGF therapies. Over to you, Antonil, sir.
Oh, so thank you so much for
Thank
the
you.
introduction. And I'm sharing my slide now. I hope it's visible now. And hope I'm
Not yet.
audible.
You're audible, but your slide is still not visible.
Yes, it's loading. I hope it's visible now
Yeah,
in the
yeah.
full screen.
This is visible, sir,
Okay.
in full screen.
Okay. So good evening, everyone. So the central question of this presentation is very simple today. So in the era of newer anti-VEGF agents, do we truly need to change, or do we need to think more carefully about disease control, response assessment, and long-term outcomes? So the title of my presentation is Evaluating the Need for Change, Evidence and Insights on Anti-VEGF Therapies. So these are the financial disclosure. So the anti-VEGF options currently used in wet AMD or neovascular AMD includes bevacizumab, ranibizumab, aflibercept, brolucizumab, and faricimab, except the first one, which is not FDA approved. And although there is no cure, timely treatment can dry the macula by inhibiting new leaking vessels and can improve or maintain visual acuity over long periods. However, the important question is that the real world barriers often prevent us from reaching these theoretical goals consistently. So, what are the challenges in wet AMD management using anti-VEGF? So, there are major inter-individual differences in response, and outcomes depend on multiple factors like age, lesion characteristic, lesion duration, baseline visual acuity, and even genotype related risk factors. So this slide also emphasizes that there is no universal consensus on how best to define the optimal response or lack of response. So this is a practical framework for the response assessment. The primary response is assessed 1 month after the last loading dose, while the secondary response is assessed later and does not necessarily mirror the primary response. So this chart very clearly showed that what is the definition of good response? It is absence of subretinal fluid, intraretinal fluid, or intraretinal cyst, or a reduction of central retinal thickness more than 75%. While the poor and non-response means the reduction of 0 to 25% in CRT, or persistence of subretinal fluid, intraretinal cyst, or appearance of new IRC, IRF, and SRF. So switching to newer anti-VEGF agents, is it really hope or a hype? So these are few real-world studies practically done in different parts of all over the world. So there is Mukai et al. Truckee study, Moorfield study, and Far Retina study. So this slide compiles several real-world data sets and showed that the visual gain after switching to faricimab were limited in multiple cohorts. In treatment-naive eyes, gains were more visible, but in eyes which were switched from aflibercept to faricimab, the improvements were small, including about plus 2.2 letters in as seen in the Truckee study, even minus 0.1 letters in Moorfields, and after 4 injection also, and plus 0.3 letters in switching arms of Far Retina. The Kotaoka et al. Study by them. In that study, 92 of the patients who switched from the aflibercept to faricimab discontinued the treatment due to insufficient efficacy. So this is a very striking statistics. It also shows that no change in visual acuity with 70 letters at baseline and final visit among those continuing treatment, and only minimum central retinal thickness change of about minus 17.9 microns from the baseline to the final visit. So as the data set involved 130 eyes previously treated with aflibercept, this study makes it very relevant real world signal for us. So another study by Kishi et al. showed that 71% of those who switched from aflibercept to faricimab remained on less than Q8 intervals. Means in those patients, in the treat and extend regime, the intervals were not prolonged up to 8 weeks even. So this study also adds some real-world perspective in eyes previously treated with aflibercept. In this study, the mean BCVA did not change at all at any time after 3 faricimab injection, while the anatomical outcomes were mixed. The CCT did not change significantly, although the CRT, that is central retinal thickness, decreases significantly. Again, as the most of the eyes were not extended meaningfully with more than 70%, still needing less than 8 weeks of interval. Next are few another studies like Hara et al., which showed that after 3 loading doses, significantly better visual outcome were observed with aflibercept compared to faricimab. Another study by Bailey C. et al. Showed that 6 months of real-world study with faricimab, and it showed a limited visual gain in those cases. The real question arises that could targeting the additional pathway beyond the VEGF pathway is actually beneficial? So this is the molecular basis of these anti-VEGF molecules. So different molecules have been tried. Like we all know, aflibercept blocks the VEGF-A, VEGF-B, placental growth factor, all those pathways, and the nesvacumab targets selectively the Ang2. The recent drug, which is faricimab, it targets both VEGF-A molecule as well as the Ang2, that is angiopoietin 2 pathway. And we all know the mechanism of action of brolucizumab and ranibizumab here. So several different approaches have been attempted in an effort to improve patient outcome, which I've already discussed. So the TENAI LUCERNE, we all know, these are the landmark trials, which showed that faricimab was non-inferior to aflibercept 2 mg for mean base-corrected visual acuity change, but it never showed any superiority over aflibercept. So now let's come to some preclinical data. This slide moves into the pathway biology and suggests that the VEGF is a key driver of Ang2 production, and the anti-VEGF therapy can also block VEGF-driven Ang2 generation. Within this preclinical rabbit model, the aflibercept shows the most durable effect in blocking the effect of human VEGF on Ang2 levels. Now, preclinical study findings should always be interpreted cautiously, but the biologic methods support the centrality of VEGF pathway blockade. So we can come into the conclusion the VEGFR pathway remains the master regulator in the retinal diseases. So we all know that aflibercept is the only widely approved agent that blocks all VEGF receptor 1 ligands and the key VEGF receptor 2 ligands also. So the broader ligand coverage is biologically important because it includes VEGF-A, placental growth factor, and VEGF-B pathway-related signaling represented in the presentation. So the aflibercept is not another VEGF molecule. It's a broad pathway blocker with strong biological rationale. So just to summarize, with aflibercept 2 mg, already targeting key ligands of the master regulator of VEGF pathway, there may be limited potential for improvements in the functional outcomes for the patients. And increasing the molar dose of anti-VEGF agent may have the potential to offer patient more through extended VEGF suppression. So to conclude, aflibercept is not standing still as an old standard. It remains like a living benchmark. Thank you so much for your attention.
Thank you so much, Antonil sir, for your presentation and in-depth presentations. And yeah, so we are parking the questions for that sessions, for the end of the session. So we are directly moving to the next talk for the Dr. Shubham Shina Roy. Dr. Shina Roy will take us through the presentation, the evolving role of aflibercept in PCV, APVRS insight, and comparisons with anti-VEGF agent. Over to you, Shina sir.
Thank you. Thank you. Just
Thank
sharing my slides. The slides are visible.
Yes, it's visible, sir.
Okay. So here I'll be discussing about the evolving role of the aflibercept in PCV as per the APVRS insights and also in comparison with certain anti-VEGFs which are newly launched in the recent times, and how head-to-head comparison will tell us that aflibercept is also the benchmark that has already been discussed in the previous two presentations. So this is my disclaimer. So if you talk about the APVRS guidelines, say once a diagnosis of PCV is confirmed, even by the SSOCT standards, there are certain criteria like sub-RP ring-like lesion, ANFAS OCT complex RP elevation, or a sharp PD, which was already been described by the Asia Pacific group in the PCV work group. That what are the OCT criteria of a PCV? And once, if you are diagnosed with a PCV with the help of OCT, and if you have the other facilities like ICG and FA, and they confirm the polyp, then you can start your treatment. So the treatment, there are two arms. One is the anti-VEGF monotherapy arm they have described. One is a combination therapy if you have access to PDT. So till date, we have no access to PDT, but recently we know that Orolab has come up with a Dyne, which is already in the trial basis. Maybe in short future, everybody will be having that Visudyne again. So once you are treating with a monotherapy or a combination therapy, you have to monitor the response. And once you have a complete regression of the polyp, you can switch on to the gradual treat and extend regimen. But if you see a persistence or a recurrence of the disease activity here, so you can shorten your interval of treatment regimen by 2-weekly therapy, or you can combine again the treatment with a PDT or switch to any other anti-VEGF agents. Similarly, if there is a large submacular hemorrhage, what usually you see a polyp present, so you can go with a pneumatic displacement with or without vitrectomy or a TPA injection. And if there is any extrafoveal polyp you see about, you can definitely go for a thermal ablation of the polyp along with the anti-VEGF. So this is what the APVRS guidelines talks about, very much similar to that our Indian VRS guidelines and the PCV that we have. So the conclusion is the monotherapy with anti-VEGF agent in many cases of PCV can be considered, and the consensus state of 95% of them agree that monotherapy works well even with the PDT. And today there are no data exploring whether the faricimab or the brolucizumab monotherapy are non-inferior to combination therapy like in aflibercept in patients with PCV. So if I talk about, just to summarize that molecular structure of all the anti-VEGF we did to come across, the molar dosing may be highest in brolucizumab, but the binding affinity is highest in the aflibercept. If you compare even the newest molecule faricimab, a binding affinity which is described as a KD value, which is very much similar to ranibizumab, but it is at least 100 times weaker than that of the aflibercept to talk about. And if you talk about the targets, so aflibercept mostly target only multi-targeted 4 arms they are targeting, wherein rituximab and ranibizumab and brolucizumab are targeting a single arm. And you all know the faricimab is a 2-arm VEGF and an angiopoietin arm to target with. So still aflibercept scores more. So if you talk about these two landmark study, VIEW 2 and the PLANET study, and they also showed that the PCV can be treated similar to that neovascular AMD. So in this left-hand picture in the VIEW 2 study, if you see the sky color column, which shows the non-PCV group, and the cream color yellow column will show the PCV group. If the similar monotherapy was being given to both the patients, and if you see the net gain of BCV was almost similar, +9 and +11 in both the groups, and with this aflibercept monotherapy. Similarly, the PLANET studies they shown that the mean change in BCVA at 96 weeks in both the aflibercept monotherapy group, which is shown in the blue column, and also the aflibercept with a rescue PDT group in the sky column. If you see that BCVA gain is almost comparable, even monotherapy group had a higher BCVA gain than the rescue PDT group. So the Planet study that tells us, that is a controlled double-masked multicentric study across 62 centers where the aflibercept was initially given in 2 milligram doses and 3 monthly doses, and then the randomization was done after week 12. So one arm was received QH interval aflibercept, or it required a rescue treatment in the form of a sham PDT. The another arm have a aflibercept QH interval or a rescue treatment in the form of an active PDT. So they continue at this point of time at till week 52 at the end of 1 year. And after the primary endpoint, the next second year, they have started the treat and extend regimen of the aflibercept with a rescue sham PDT, or in the second term, they have kept the aflibercept treat and extend regimen with the active PDT. So what do you see in the 96-week trial after the end of second year? You see the two arms, that is an aflibercept 2 milligram with a rescue PDT, which is showing with a sky color line, compared to a blue solid lines that is showing the aflibercept monotherapy. At the end of 96 weeks, the BCVA gain is almost comparable, even more in the monotherapy group. And if you see the average number of injection required in the first year is 8.1 in the aflibercept monotherapy group, and it is 4.6 in the second year with the treat and extend regimen. So it tells us the durability and also the sustainability of the aflibercept, that the number of injections quietly decreased in the second year onwards. So there is another, that's telling us the treatment burden, how it reduces the cost of treatment burden. So it is two columns, one with patients with a Q10 interval in the Planet study at 96 weeks, another set of patients who has maintained with the Q12 interval. And you will see in both this group, aflibercept monotherapy and rescue PDT group, you see the BCVA gain is almost comparable. And if you see the mean number of injections of both the group in the second year, that is 52 to 96 weeks, is considerably decreased to 4 to 5 injections in both the groups, which tells us if we adequately treat in the first year of the life of the PCV, then in the second year, definitely the number of injections will consistently going down, reducing the treatment burden. Also in LTS study, the vision gains, they have told they are 2 milligram aflibercept treat and extend regimen with or without a PCV. There is the two groups they have studied. One is the PCV subgroup over here, and another is the non-PCV subgroup. So the two arms you can see, one is a 2-week adjustment treat and extend regimen, one is 4-week adjustment treat and extend regimen. Similarly with the non-PCV group also, they have been shown the two arms, one is the 2-week adjustment, one is the 4-week adjustment. And if you see the mean number of injections, in both the arms, at year 1 and year 2, in the PCV group, the first year received 7.1 and 6.7 in both the arms in 2 weeks and 4 weeks adjustment treat and extend regimen. But in the second year, considerably they are almost half, reduced to half, 3.4 and 3.5. Similarly, for the non-PCV group also, if you see that requirement of injection in the first year, the second year it is reduced to the almost half of the first year injections, which tells us the treatment burden is decreased with continuous monitoring and treatment protocol. So to compare with, if you see that, the two groups which is maintained, one with a Q12 interval and one with a Q16 interval in the PCV group, the mean last treatment interval was almost 12 weeks. So they are at least maintaining the 12-week interval, treatment-free interval in both the arm groups. Similarly was also observed for the non-PCV group, where they too have shown that last treatment interval was somewhat between 12.2 to 12.4 weeks, which tells you that it gives a considerable amount of treatment-free interval in the next year of PCV. So other studies also are supporting that what Planet and View study has told us, that Maruka et al. Reported the similar outcomes they have shown even in the PCV and the AMD groups, that in first year, if you see in the PCV group, the mean number of injection was 7, which is reduced to 5 in the second year of injections. Similarly, the AMD group also, the first year it was 7.8, the second year was 6.5. So definitely, if you see, it was a total of 12 injections in 2 years in the PCV group compared to 14.3 injections in the neovascular AMD group in the two arms of studies. So definitely, it will tell you that in the long term, the patient will have much reduced treatment burden if you stick to the treatment protocol. The real-world studies that are shown side-to-side parallel studies, that is Hosokova M. et al. In 2017, they show that if they have started the baseline of 66.5 BCVA ETDRS line, at the end of 1 year, they had a gain of 8 plus 8 ETDRS study, and the 12-week interval, almost 60% of the patient was able to maintain a 12-week interval after the study. Similarly, in the Morrison and the Hosoaka study also similarly in year 2, they found that almost 47 to 50% of the patients were able to maintain the 16-week interval with a BCVA gain from the baseline is about a +9 ETDRS study. So if terms of complete polyp regression, if you talk about across the real world studies, there are so many studies that I've quoted here compared to Volt study, Saito study. So the blue columns that you see is the Japanese case series, and the Volt study also tells you in most of the studies you will see that in 60 to 70% of the cases there was complete polyp regression, which was confirmed with even ICG also, which is a very good number even with the absence of rapidity also. The monotherapy was able to regress the polyp. Recently, we have a Selvin study that was a landmark study for faricimab. But if you compare the two head-to-head study, the Planet study is always a multicentric double-mark study, and it is a randomized sham control study. But a Selvin study, it was an open-label study, means it was not masked, no masking of patient was done, and no patients investigated was masked to superiority or sham like the Planet study. And they don't have any arm. It was a single-arm study because faricimab was only used and there was no comparator like in Planet study where there is two arms, one with a monotherapy, one with a rescue PDT group. But if you see that primary endpoint, that the two groups, if you consider the non-inferiority aflibercept monotherapy versus rescue treatment, or BCVA change from baseline to week 52. Similarly, in the Selvin study, the mean BCVA change, averaged over 40 to 48 weeks. And polyp assessment was basically made by the ICG in the case of a Planet study, and absence of polyp or absence of leaking polyps is confirmed with the ICG. Compared to in the Selvin study, ICG was used to confirm the PCV at the baseline, but then ICG and OCT was used to assess the polyp regression and activation. But only 77% had a confirmed diagnosis of PCV by the CRC protocol they have stated. So this should be, understood that the priority protocol are different, and not a single, study can be compared with other because of the different model they have used. But if you talk about the Hera et al., which tells you that comparison they have done between the aflibercept and the faricimab group, and this faricimab patients, also that aflibercept patients have received 3 loading doses in the starting point of time. And if you see in this logMAR chart of the BCVA, after 3 months, they have showed after the 3 loading doses, the aflibercept group had a much better BCVA improvement compared to faricimab group at the end of the 3 months. And if you see the proportion of exudative change, in terms of SRF, IRF, or sub-RP fluid, you will see that the aflibercept showing a much more decrease in the exudative changes compared to faricimab in the 3 months. And if you talk about the polyp regression percentage in both the groups, where the faricimab was showing 33% regression compared to aflibercept group who are showing a 44% regression. So if in a head-to-head trial done by Hera et al., aflibercept scores better than the faricimab. So the conclusion of the Hera et al. Studies was that even they compare head-to-head study in real world in the Japanese population treatment-naive patients, both are effective in reducing exudation and treatment thickness. But aflibercept was more likely to eliminate the exudative changes a little faster, with a little more improvement in the visual acuity after the loading doses compared to the faricimab. But maybe in the long run, both of them will be equally comparable. So the conclusion was the aflibercept 2 milligram efficacy and safety has been well established because it's a very well established for last 15-20 years that we're using. More than 90 million doses has been administered, and more than a decade we have this trust with a very safety profile and approved for a multiple or total number of 7 indications. So they told us with a very low adverse effects, it is still the drug of choice for any innovative drug. If you want to introduce into the market, it should be compared to the gold standard aflibercept that you have. So to conclude with, I would like to show 1 or 2 cases of polyp because my cases which was with the study of the PCB. So I just highlight 2 cases or 3 cases, interesting cases that have come across. So the case 1 was a 63-year-old gentleman who presented with a sudden onset diminution of vision in the left eye for last 2 days. And he had a presented vision of CF shape in the left eye. Right eye was completely normal. And if you see the presentation, the right eye was normal if you see the fundus photo, but the left eye you can see over here, there is a fresh subretinal submacular hemorrhage at the center with a orangish lesion seen at the center of the macula. So if you have gone through that, this OCT, if you see the right eye has a normal OCT, the left eye you can see the submacular hemorrhage, you can see the small BVN over here. And ICG was not performed that time, but definitely it was looking like a polyp. as per the OCT. So the treatment options, if you talk about, we can treat these options as an anti-VEGF only. We can have a PDT with combination anti-VEGF. We have options of PDT. You can do a pneumatic displacement with the anti-VEGF treatment, or you can do a vitrectomy with a subretinal injection in the first. So considering all the 4 options, I prefer to choose the least invasive treatment because the PDT was not available in my time, and we treated the patient with a pneumatic displacement with anti-VEGF injections. So if you see after the second dose of injection Eylea, and the first dose was combined with a C3F gas injection, and you see how nicely the macrophobia has back to its normal contour. You can see how nicely the submacular hemorrhage is resolved completely. Only a small amount of hemorrhages was there left over. So you completed the third injection loading dose of injection Eylea, and you can see the BCV has improved to 6.9. There's complete regression of the submacular hemorrhage with complete restoration of the foveal contour. You can see how nicely the polyp has also been regressed, and there is no reactivation after that. And I followed the patient subsequently in 2023 March, and now in 2026 June, last patient came. Sorry, it is not 2026, 2025 June. You can see that there is no activity again coming back, and patient is still maintaining a good amount of 6.6 vision. So the case 2, if you see here, if say 57-year-old gentleman, he was complaining of a floaters with diminution vision in the left eye for last 2 to 3 months. He had some certain rheumatoid arthritis, dyslipidemia, hypertensive history, but he consulted LBP Hyderabad and he was diagnosed with IPC with a submacular bleed, for which he was treated with a pneumatic displacement with the injection Eylea. And his vision at my presentation where he was presented to me was 6.9. So this was the presentation picture when he presented to me. You can see the right eye, there was some sort of RPE changes over here. And in the left eye, you can see the myelinated nerve fibers on the disc, but you can see some amount of hemorrhagic PD or some PD over here just between the fovea. So you have done that OCT about through the lesion. You can see this excavation is what you see in the fundus picture in the right eye. The left eye is still showing a very active hemorrhagic PD, which tells us that although there is no SRF, IRF, but the disease, the polyp is still active. So we completed the third dose of injection, and after 2 months follow-up, we can see that height of the polyp is consistently regressed. It is reduced. The foveal contour is well maintained. The patient is 6 inch, patient is happy, and he left over. Although the patient was asked to follow, every 2 monthly because the PCV has a very high chance of recurrence. But patient was happy. He went back. He didn't turn up on time, and that after 2 months or 4 months, he came to us with this picture. You can see a massive submacular hemorrhage. The macula is elevated, and the hemorrhage is also surpassing that superior arcade. So the patient was immediately subjected to C3F with Eylea injection. And you can see after the displacement of that heme, that nicely heme is cleared, but the fovea is accidentally thinned out this time, not like the before fovea that he was having 2 to 3 months back. So patient was given second line of injection Eylea, and he went back. But in subsequent follow-up, you can see the patient has developed a macular hole. This is because of the contractile forces you can see over the lesions, the foveal thinning. The macular hole increases in size with no activity coming back. And because it was a polyp, so we didn't go for a vitrectomy for a macular hole initially. We're thinking that the patient might require anti-VEGF treatment later on if there is activity coming back. We keep on following the patient with a vision of 6.36. And surprisingly, at 6 months of follow-up, you will see that there was spontaneous closure of the hole because of a secondary ERM development with a contractile force. The retina was pushed inward towards the fovea, and the spontaneous closure of the macular hole was there. So you can see in the literature actually, there's one case report by the Girdhar et al. Where they have similarly encountered this spontaneous closure of the macular hole. Although the mechanism was different, it was with injections. In our cases, it was a ERM formation which was causing the macular hole. So last was the case of the case 3, which was a 43-year-old lady who presented from Arunachal Pradesh and complained of a black shadow in her right eye for last 2 months. She had a history of thyroidectomy and hysterectomy in 2022 and 20, and BCVA was right eye was 6.9, left eye was 6.6. So this was the picture. If you see the right eye, there was some kind of exudation and some sort of pigmentary changes over the fovea. The left eye is looking normal. And if you see this corresponding OCT, you can see the left eye OCT is normal, but the right eye, if you see that there is a fibrovascular PD with some SRF with IRF also over here. And underneath, you can see that a blackish mass just compressing the choriocapillaries, which tells us there is a component of a choroidal nevus. So if you see this picture, this was patient received the injection of Xenflix. But if you see that not much change in the anatomical OCT, the function was also almost same. There is a consistent amount of IRF and SRF still persisting and not much improvement you can see. So the patient was switched that time to another injections, but patient was lost to follow-up. She revisited to us after 3 months. You can see how that fibrovascular PD component has grown, how the IRF is increasing, and it is increasing the exudation we noted. So this time we convinced the patient to take the injection and switch for the Xentrix injection. And but if you see that, if you go about the case, you can see the disc. The disc, there is a margins are, the two margins are blurred, telling us there is some kind of a abnormality. Disc edema is there. But if you go through the OCT of the disc, they'll show a buried drusen over here. If I do a autofluorescence, they'll show you the nevus, which is nicely shown as a hypo AF picture surrounded by the hyper AF, which tells us the nevus. And this is the polyp, surrounding that nevus, which is very commonly reported in literature that nevus compressing the choriopenetrator can sometimes go lead into the PCB formation. So multifactorial diagnosis if a patient with a right eye PCB with a choroidal nevus with acetovenous drusen in both eyes. So patient was switched to injection Eylea, and if you see after 2 doses of Eylea, how nicely the patient has regressed, the IRF and SRF has come down, the height of the polyp is coming down, and patient is doing absolutely fine. And you can see in September 2022, patient was doing absolutely fine. With March 2022, there's some pigment migration. Apart from that, everything was absolutely fine. But in December 2023, if you see that the height of the, polyp was still increasing, which tells us it's an alarming sign, you should keep the patient in close follow-up. So the patient reported after 2 months in February 2024, and you see that now two new foci of this polyp has grown up, which was separate from that original position, which was over here. We can see two extrafoveal polyp grown in the temporal area. So the patient was immediately advised to laser. The parent was to do an injection, decrease the exudation, and do a laser later on. But subsequently, the patient was lost to follow-up. But still, patient is yet to come back. But it was an interesting case to come across. With this, I'll conclude my talk. Thank you.
Thank you so much, sir. Thank you for the all wonderful cases and yeah, definitely crystal clear and that flawless presentations. So
Thank
with
you. Thank
this,
you.
yeah, thank you so much, sir. So with this, we are heading towards the end of the session. So we just like to address few of the questions, maybe out of total sessions, out of 3 talks. So this forum is open for audience. So we are happy to take your query.
Very nice presentation, Shubham. Your cases are very nice. Have you tried
Thank you, sir. Thank you.
biosimilar, this new biosimilar which has come up?
Anaira.
Yeah.
So the person is roaming around me and here and there. He was trying to convince me, but the moment he approached me, I think a week later there was a BRSI circulatory notation regarding that 5 cases that have received about the
Yeah.
adverse drug reaction or the steroid
Before
inflammation
that,
and
many
all.
people have tried actually. Before this,
Actually, I think in
right?
February 2026, I think it was introduced, I think first time or March
Yeah,
something. But I was like, okay, let it give for 1 or 2 months. Let me see because I know, I remember even the first resume thing which come up, and then there was my haywire because of some reaction, the batch was changed. So every biosimilar when they come, I actually observe for 3 to 4 months minimum before getting introduced in our institute because some sort of sterile reaction or something we listen from many of the centers institutes. So I'm
yeah,
little hesitant to start with before seeing the more safety concern rather than the efficacy of the drug. Because efficacy is one thing that you can negotiate with some patient or switch, but if there is some hazardous reaction, it becomes difficult for us to convince the patient. Although I think VRSI has given a new circulatory that changing the batch number and bringing a new batch, then they have allowed them to use again. And they're trying to push us that the batch number is changed, that batch has completely been withdrawn. And I think in 2000, this May 29th onward, they have started the new batch, which is not even 2 weeks. So I think it is very early for us to give. So whether you have tried, sir, in SN or
no, we have not tried. We have got few samples, but I have not tried. My colleagues have gone through, but they have gone with a good results only. They didn't had any IOI or anything, and the efficacy also. But it's too early to say, as you said. And any
Yes,
drug,
sir.
it takes its own time to get in its space. Antaril, you also had any experience in biosimilar?
No, sir. Currently, I'm staying away from this due to those incidents. Maybe after 3 months, I'll think of it. Another good thing is that the original Eylea, the innovator molecule, they have decreased the price also, so it's becoming more
My
Yeah,
affordable.
that
question
is
is, sir, even for sir
right.
also, after they have withdrawn the patient support program, whatever price they have quoted, I know some institution wise they can vary 3, 4, 4, 5,000, but whether we are noticing a dip in the treatment program, the frequency, because some patients will be like, if I receive 5 injections, still my total expenditure will be more than I used to get in a patient support program. So that is one concern patient, and few of my patients have compelling us to switch to another anti-VEGF where they're getting some free injections, because although they have curtailed the price, but the cumulative cost of all the 4 or 5 injections, I think, is still more than that what they used to get in the PSP support program. So nowadays patients are very clever, so they uh, calculate it like that, that if I receive 4, 5, 6 injections, how much I'll be spending versus that PSP support that I used to spend before. So this is one challenge that I'm facing. Irrespective of the drug, it remains the same. That is the best part. And I think Eylea 8 will be launched soon, but I think there was some delay. It was supposed to be launched in June or July, but I hope it will be delayed for some more months, I think, for some DCCI approval or something. So,
Yeah, I also feel some hesitancy of patients taking now Eylea because of this only patient support program.
1 or 2 injections, it is okay. But
Uh,
now to give a repeated injection, even the loading doses, it becomes some challenges, and
However, patients
because
are, as you say, no, they are more
yeah, they
attracted
calculate
towards
like this.
freebies, yeah.
Freebies. So they'll see if I get some extra free injections, why it is better. This is uh, costing me less compared to the 4 or 5 injections of Eylea now. So, and even till date, Eylea was the single, I can say that brand in this territory. But now this year, because they are competing with the biosimilar also, and
Okay.
even in 3, 4, 5 months, there are 4 more companies coming up with their biosimilar of aflibercept. It will be almost like a ranibizumab like picture, where every company will coming up with a aflibercept biosimilar. So now
It's
the
good for the patients. Nothing.
yeah,
Yeah,
that competition will be for the price mostly. Definitely, efficacy is one more thing, and adverse effect is one
Efficacy.
more thing. Adverse effect is one more thing to watch out, because what I feel that biosimilar batch-wise efficacy can differ, sir. That is one thing I have noted. I don't know how. Even the adverse effect also it differs from batch to batch. What we don't see with if I still talk about the eccentric, sir, yeah, till today it is such a safe drug, irrespective of so many biosimilar they have come across. Same for the Eylea also. It is such a safe drug. Even if you give an inflamed eye, uveitic eye, you would never see a secondary injections. So this kind of uniformity is very difficult in biosimilar groups. I don't know. They can have the patent formula to do it, but that efficacy and the uniformity in every batch maybe it differs. What I feel. Same for ranibizumab. I have seen the biosimilar of 3, 4 companies. I think they are
Yes.
not giving that comparable results that I used to see with eccentrics. So
Hmm.
that is a variability is there.
So you advise all patients first treatment of line, irrespective if the money is not a issue. Which agent is your first choice for DME?
Sir, so for DME, sir, basically, if I truly speak, money is not an issue. Eylea and Vabysmo will be my first choice, because I have given both these injections and I have seen good results in both the arms. And because now Eylea has stepped out from their PSP support program, and Vabysmo has done the opposite. So they have stepped up their PSP support program. So
Yeah.
in terms of number of free injections, so that I think if you see the competitive wise in the market wise, now the patient, if they compare that which will give me less expenditure, the patient will move towards it. Otherwise, efficacy wise, I would go with to start with Bevacizumab, or if any both are equally okay for me. I will let to the patient that whatever you feel as per your expenditure or profile and all, you can choose. But Pagenex, I have little shifted off actually for now, because I have received 3 or 4 bad adverse reactions in my institute,
Okay.
even 4 to 5. It was also a good drying effect was very good, but after that incidences, it has substantially not from me, all other 4 consultants. For each consultants, we have 1 or 2 adverse effects from Pagenex, and the
Okay.
problem was it was not happening in the first injection. It was happening even in the
Yes.
second, sometimes in the third injection. So the predictability was the issue, because once a patient requires multiple injection, at what point of time it will inside the inflammation, it is uncertain. It is not that the first injection has saved, the second will also be the same. So in a DME patient, sir, if you say me, yes, Eylea or Bevacizumab will be my first choice. And I am not a very keen for a biosimilar, because I'm giving biosimilar considering the patient thing and all. But I feel the response varies, and the safety profile also is a question mark, unless we have a track record of Resumap like last 7, 8, 10 years now. Resumap, I know that it is doing pretty well with no much inflammation with the current batches. But all other companies are trying out with their own biosimilars, and mostly at the end of this year, Eylea will have 4 or 5 more
Yeah.
competitors in their pipeline.
Yes, yes. Anthony, your choice for DME first, Eylea?
Sir, I am a little more conservative person. Eylea is my first choice because I have limited experience of Vabysmo in treatment naive patients.
Okay.
But if in non-responders, generally I shift to them. Otherwise, Eylea is, I think, the safest and most predictable choice,
Oh.
especially in vision less than 6 by 12. If the vision is 6 by 9 parts or 6 by 12, then I give the patient option that see, both eccentrics and Eylea both will work. If you can afford, go for Eylea. If your budget is tight, then you can go for eccentrics as well.
And
Truly
vascular,
speaking, in Indian scenario, a patient with a 6'6" partial or 6'9", it's difficult to convince the patient also to get
yes.
injection. They will
No,
never
no, sir.
present to
The
you and
6'9" parts are 6'12". In six
that's what,
parts, I don't inject.
unless it is 6'18", 6'24", it's nothing bothers for the patient.
Yeah, that's true. That's true, sir. We counsel the patient, and rest is up to them.
Only a very few sectors of intelligent patients who are very cautious about the vision, they will understand the
Exactly.
difference between 6'9", 6'12".
We also
Otherwise, the
counsel
patient
that
who are
the injections, if the deal injection, the vision gain will not be there because the cyst will
because the
become
improvement,
more.
improvement is not much. From 6'9", I can give it to 6'6" only. So that is also patient who is okay. Almost, if you ask the patient, ठीक दिखता है, almost एक ही है. So that is one thing that I face. Unless the patient drops down by 6'18" or more, they don't realize the improvement also.
Right.
And are you using for vascular occlusions also? CRVO, BRVO, Eylea?
Yes, sir.
Using
I am
it.
using in vascular occlusion. I
Good.
preferably tell the patient that
Getting
this will work best.
as a nave or
In
switching
both,
it.
sir. In both cases, sir. Eylea, I think, particularly worked very well in a few recalcitrant cases. Also, after one injection, everything got dried. I don't know, and there is no clinical trial supporting that Eylea is better than other molecules in vascular occlusions, but in practical experience, I think it works better.
Because in India, technically, the disease,
Yeah.
although we have the other studies supporting outside India, but in India, it's not still
It's
yet.
approved by FDA, sir, but we don't have
Yeah,
DCGI one.
this is
In
But in
India,
India.
actually, I
But
usually start with the ranibizumab eccentrics, and because of this DGCA approval and all. But yes, but you can give, because my patients are also receiving even Bevacizumab, which is off level for retinal vein occlusion. But their standard of guidelines is PCB, AMD, and
but I
DME.
think this Anaira biosimilar has approved by DCAJ for vascular occlusion.
yeah,
Is it?
Anaira, sir.
yeah,
Okay.
Yeah, they got
Sure.
that approval, sir.
Yeah, they got that.
They got.
That is what more surprise.
That's strange.
Yeah. Anyways, thanks. This is quite a good discussion. Thank you so much.
Thank you so much, sir. Thank you. Thank you,
Thanks.
everyone. Yeah, thank you, Antonio sir. Thank you, Shubham Sinha sir and Ishnigam sir for the discussions and all audience. Yeah. Good
Thank you.
night, sir.
Thank you all.
And yeah, we'll meet soon on next meeting, I think.
Yeah.
Thank you.
Good night.
Good night. Good
Yeah,
night.
Good night, everyone.
Good night to all.